talk about, but probably not many of us do. When do we use it? Well, it's mostly when there's actually this pus there, it's more likely for you to get a good yield. But when you're worried about bugs hiding behind the biofilm, that's when you need to sort of send, like in aseptic revisions, that's when you really need to send that implant in some saline for sonification, and that will actually take away the bugs from the biofilm, and that solution then you can culture, or you can use it for other molecular tests. So sonification gives you all the organisms or maximum possible yield, and that you have to put to various tests. So you can put it to culture, or you can use a molecular diagnosis. So what are the molecular diagnoses that can be used? I think some of them have already been talked about. I'll try and put it from an orthopod's perspective. PCR, what is it? It's basically just amplification of the genes of the organism that is there. It's like searching for a needle in a haystack. So if the organism is there, you will find it. You do whatever tests you have and you can get that. So basically, if you have multiple organisms, there's two ways you can do this. You put a PCR for each of those organisms, but that's a long process and can take a long thing. So alternatively, you have this thing called the multiplex PCR. So you use different primers for different organisms, and using the same sample in a particular testing device, you can actually test multiple set of organisms all using the same PCR technique. So you have this thing called the BioFire, which everybody keeps talking about, which can look at about 30 organisms, most of them gram-positive and gram-negative, and one fungus. And you can get the results within an hour. And as previously mentioned, you sort of get the most common organisms, that is the Staphylococcus and the gram-negative organisms. And not only that, it can tell you the gene for a particular resistance. So if it's resistant to vancomycin, it'll tell you. But you won't know which organism is actually resistant to vancomycin. All you know is that one of the organisms is resistant to vancomycin. But there's a major flaw in this whole system with BioSure. Because of the cross-reactivity and various other issues, you will not be able to pick up coagulase-negative staph. You will not be able to pick up Cutibacterium acnes, which we talked about. And that is a major problem. Second, it'll also pick up the genomes of the dead organisms. It'll also pick up the genomes of the contaminated ones. So really speaking, is it worth it? It's got a sensitivity of 54%. I mean, even culture has got a better sensitivity than this. So why do we use this? And in fact, if you look at the various studies looking at this BioSure, it's very useful in pediatric infections. So when you're looking at Kingler Kincaid or various other things, and you want to know, is this infective? What kind of antibiotics do I need to give? Yes, it may be useful. But its role in PGI is very limited. In fact, don't waste your money on BioSure is what I would like to say. So you have this other thing called the next-gen sequencing or metagenomics, which somebody talked about. It's slightly different from this PCR, because here what you're basically doing is you're sequencing the DNA and sort of looking at it at a whole library of genomes that you have and trying to see which of those genes that you pick up. So it'll actually pick up all the bacteria that can possibly be there. And that's obviously a much longer procedure, but it's more complete. It'll tell you whatever organism there is, I mean, fungus or atypical bacteria, all those things can be picked up. And so you have a very relatively good sensitivity and a good specificity for this next-gen sequencing. But again, the problem is that you can pick up these dead organisms and contamination. So what is the role of all this molecular diagnostic as of now? It all boils down to a high index of suspicion. So which is why, the Parvazi's definition is very important. If you have a high clinical suspicion that yes, there's infection, and if you have a negative culture, that's when these will probably help. The BioFire panels probably is not really useful, so don't invest your time in that. But those are the situations in which you can do a next-gen sequencing. You can find out whether you missed out an organism. So this is probably where the molecular diagnosis will come into play. So you've got a whole lot of techniques in this molecular diagnosis, but really speaking, cultures probably still is the gold standard. Now, I'm supposed to be talking about antibiotics in PGI, but I think this has actually already been covered in quite a lot of detail. And the key thing that, about the antibiotics is a problem with the biofilm. And this is something that we don't talk about much in the orthopedic circle, that is usage of rifampicin for PGI. I mean, many of us don't even use it, and probably because we're all scared of the resistance with cross-reaction with TB. But there's a lot of literature, especially in the West, about the use of rifampicin for PJI. And the other thing which was alluded to earlier, now most of us give 6 weeks of antibiotics, but this is actually a landmark paper which actually came out in NEGM. 6 weeks probably is not sufficient for most organisms. What you really need is probably 3 months, and that's something that we need to think about. But most of this is when you retain the implant. So I like to rephrase myself. If you're putting in a spacer and you're taking out the implant, then probably all you require is 6 weeks of antibiotics. But if you are retaining the implant, like in a single stage revision or a DARE, 6 weeks is not sufficient. You need 3 months. And in fact, for the knee, they say 6 months. These are the recommendations, okay? So 6 months of antibiotics for a knee infection if you're retaining the implant. So these are all new things for me actually when I was reading this. So, and what they say about this 3 months, what they say is that if it's a staph or gram-positive organisms, what you need is dual antibiotics. The first 2 weeks may be IV, but the rest can be oral, provided you have an oral alternative, and you give the adjuvant rifampicin in addition. So when you look at staphylococcus, if it's, you're putting in a spacer and you're not retaining the implant, 6 weeks is sufficient. So like the previous speaker said, you either use cefazolin or vancomycin for MRSA. As when it's a combination therapy, that is you're retaining the implant, then you have to give it for 3 months with rifampicin. So that's 2 weeks of IV, whatever, sensitive, and then you can give the oral. Now, levoflox is a fantastic oral alternative. Why? Because that actually pierces the biofilm, and that can be very useful. So is the minocycline and all the other organisms there. Now, what you don't find in this list is linezolid. Why? Because it is not a good drug for long-term usage, because it's got a lot of toxicity, so it is not a drug recommended for long-term antibiotics. Rifampicin, now all of us are very worried about the reaction, especially with TB, and we should be so. So few things about it. Do not give it immediately after the surgery. Wait till you get source control. Make sure you have source control, because if you give it without source control, almost definitely you'll get resistance. So you start it only a few days after you do the debridement. Second, always use it in combination. Never give it in isolation. If you give it in isolation, you will get resistance. So even when I'm talking about 6 months of therapy for the knee, you're giving rifampicin plus an oral antibiotic, okay? Right, so gram-negative, there is no really consensus about whether you need to go on for 3 months. Most people would give it only for 6 weeks. And the usual drugs are, the drugs that I've listed down there. And if it's resistant, then, well, meropenem and ertapenem for 6 weeks is now the recommendation.
Please summarize, sir.
Yeah, so this is basically what it is. This is a summary of what I've said, that if you're going to be putting in a spacer, it's 6 weeks of antibiotics. But if you're going to retain that implant, that's when you need to give 3 months. And always a combination with rifampicin if it's staph. Knee, it's 6 months. Thank you.